Hi, Jemima. I think I'm saying your name correctly. I'm so sorry. If I'm not, please forgive me. My name is Amber, and I really enjoyed reading your post. There were a couple of things that really stuck out to me that I would love to comment on. And one of them is concerning the gap in the research that you found connected to the right drug and dose for the individual. During my research in the articles concerning medication-assisted treatment, I found one that focused in on methadone for illicit opioid use, and it really studied the effects of methadone maintenance treatment to help bring sustainability to creating management with opioid use, keeping it in a healthy paradigm rather than it being illicit and overusing. So they really found in their studies that methadone maintenance doses above 60 milligrams confer greater efficacy and retention and suppression of illicit opioid use. So I thought it was interesting that they were able to even kind of nail down a dosage. So even the fact that you brought up dosage being an important component. I do love the fact that you mentioned the individuality of the patient, which I feel like in some of these studies that was really lacking. The professor even talked about this in class on Thursday night, mentioning that there are several factors that go into this, such as the history of substance abuse, how long have they been using opioids, how often, how much. So much needs to be considered as we are dealing with the individualized patients. And so using medication-assisted treatment as an overarching solution can be dangerous. So I totally agree with that. But what I loved about Fullerton et al. Is they really gave specifics concerning methadone. They also were really intentional to mention that methadone can have adverse effects if there's a mistreatment. So they even stated, that for a healthy maintenance, you need at least 60 milligrams, but anything above 100 milligrams, they found to not be beneficial. I also wanted to comment on your mention of psychotherapy. You said, regarding the effectiveness of psychotherapy with MAT, since MAT provides a more comfortable detox than the traditional method, the individual can begin participating in psychotherapy sooner. I am a huge proponent of incorporating psychotherapy with MAT. I do want to note that in this article, when they define what medication-assisted treatment is, they include behavioral therapies, but not necessarily psychotherapy. I feel like behavioral therapy really deals with the behavior, whereas psychotherapy really deals with the emotional root that's actually causing the negative behavior. But I think it's interesting to note at the end of their article, they state there is no clear evidence that structured psychotherapy provided in addition to the psychosocial support normally offered at methadone treatment centers conveys additional benefits. So I had several questions when reading this, and more importantly, what I was questioning was timing. So you mentioned possibly bringing in psychotherapy at a sooner date rather than later. I'm wondering, in the gap of their research, was it sooner, was it later, and how timing could have affected them coming to this conclusion of psychotherapy not benefiting or being an additional benefit. So thank you so much for your post. I enjoyed dialoguing with you. Have a great day.